A 56-year-old Indian gentleman saw me way back in 2016 with an acute coronary syndrome, and at coronary angiogram noted to have critical stenosis or narrowing in his proximal left anterior descending artery. His right coronary and his left circumflex artery were at that time of normal caliber. A drug-eluting stent was implanted in the left anterior descending artery, and he was followed up closely the following 2 years. Subsequent to that, he was lost to my follow-up for the next 4 years, and when asked directly, he was not following anyone and was not taking his statin for lowering his lipids. He came back to see me in the clinic just a week ago with history of easily inducible angina with minimal exertion. At stress test, the stress ECG showed significant STT segment depression which persisted for 8 minutes in a recovery, and this is evidence of asymptomatic ischemia. He was duly persuaded to undergo a coronary angiography, and at coronary angiography, his right coronary seems like a dominant artery with long critical narrowing in the distal segment before bifurcation to the right posterior branch as well as the right posterior descending branch. This lesion, however, looked both bypassable as well as angioplastable. In the left coronary artery, the proximal left anterior descending artery showed discrete in-stent stenosis in the stent at 2 segments, i.e. the proximal portion of the stent as well as the distal portion of the stent, both fairly complex as the disease extended beyond the stent and encroaches into the unstented segment of the artery. Beyond this, and lower down in the mid segment of the left anterior descending artery, there is another tight lesion which needs to be bypassed or angioplasty. The left circumflex artery, which is a branch of the left artery and supplies the back portion of the heart on the left side, showed 2 or possibly 3 tendon lesion narrowings, which are fairly complex. And in summary, this patient, after 6 years of first time being presented to me in the clinic and had a stent implanted then, has at present complex 3-vessel disease. Given the complexity of his disease in the coronary arteries, the coronary angiogram was stopped here, and I did not proceed to do an ad hoc angioplasty or stenting. The proper decorum here is to discuss the complexity of his coronary tree the next day in clinic with patient and offer him the alternative and full modalities of treatment. Basically, he needs vascularization of his arteries, but the first choice would be bypass surgery, and bypass surgery. Second choice would be angioplasty and stenting. I have to give him time to decide on his own as to the modalities of treatment, and even for him to get even a second opinion if he likes to. At this point in time, he has not get back to me yet on what he decided to do. Subhanallah, walhamdulillah, wa la ilaha illallah, wallahu akbar, wa la hawla wa la quwwata illa billahil aliyyil azim, wa la hawla wa la quwwata illa billahil aliyyil azim, wa la hawla wa la quwwata illa billahil aliyyil azim.